3 weeks ago, I watched a 42-year-old CrossFit coach collapse mid-workout, dead before the ambulance arrived. His last words to his training partner, "I feel amazing today." 2 days before that, his blood work came back perfect. LDL cholesterol, 87, blood pressure, 118/76, resting heart rate, 52. His doctor told him he had the cardiovascular health of a 25-year-old. His autopsy revealed a 40% soft plaque in his LAD that ruptured during a heavy clean and jerk. The clot that formed killed him in under 4 minutes. I'm Dr. Eric Topol, and I've been a cardiologist for over 30 years. I've performed more than 5,000 cardiac catheterizations, and I've seen this exact scenario play out hundreds of times. Young, fit, healthy people dropping dead from coronary disease they never knew existed. Here's what haunts me. We had the technology to see his killer plaque before it killed him. A single 10-minute scan would have revealed it, but nobody looked. The good news? You don't have to die like he did. Today I'm showing you exactly what's happening inside your coronary arteries right now, why your body hides these silent killers so effectively, and the only 2 scans that can catch them before it's too late. Because the deadliest heart attack is the one you never see coming. The answer up front. A coronary calcium scan, combined with CT angiography, is the only screening strategy that reveals vulnerable plaque before rupture. But understanding why this happens, the precise molecular biology, is what allows you to prevent it. Let me show you the mechanism that kills healthy people. Why your heart's plumbing fails silently. Your heart is the most metabolically demanding organ per gram of tissue in your entire body. Every single heartbeat requires enormous energy, ATP production through oxidative phosphorylation in cardiac myocytes. To fuel this continuous demand, your heart relies on its own dedicated blood supply, the coronary circulation. Picture your heart wrapped in a vascular network. These vessels branch like rivers feeding tributaries. The 2 main rivers are the right coronary artery, RCA, supplies the right ventricle and inferior wall of the left ventricle. The left main coronary artery splits into 2 critical branches. Left anterior descending, LAD, supplies the anterior wall, and apex circumflex artery supplies the lateral wall. The LAD is the single most dangerous vessel. We call it the widowmaker in the cath lab because complete occlusion here means massive anterior wall infarction, often fatal within minutes. But here's the paradox that confuses patients and physicians. How does someone with 0 symptoms, normal stress test results, and optimal blood work suddenly die from a coronary blockage? The answer lies in how plaque actually develops and behaves, the endothelial injury cascade. Let me walk you through the molecular biology that creates atherosclerosis. Your arterial wall has 3 distinct layers: intima, innermost, a single layer of endothelial cells; media, middle, smooth muscle and elastic tissue; adventitia, outermost, connective tissue. That inner endothelial layer is your first line of defense. In healthy arteries, it's slick and non-adhesive. Blood components slide past without sticking, but several factors damage this protective barrier. Hemodynamic stress, areas of turbulent flow, branch points, curves, experience higher shear forces. Over decades, this mechanical stress creates microinjuries. Hypertension, elevated pressure, physically stretches and damages endothelial cells. It's like overinflating a balloon repeatedly. Eventually, the material weakens. Hyperglycemia, elevated blood glucose causes glycation of endothelial proteins. Think of it like caramelizing the inner lining. It becomes sticky and dysfunctional. Oxidative stress, free radicals from smoking, inflammation, or metabolic dysfunction directly attack endothelial cell membranes. Inflammatory cytokines, chronic low-grade inflammation from obesity, autoimmune disease, or other sources, activates endothelial cells and increases permeability. When endothelium gets damaged, the cascade begins, from injury to atherosclerotic plaque. Once endothelial integrity is compromised, LDL particles can infiltrate the arterial wall. Phase 1, LDL entrapment. LDL cholesterol particles are small enough to slip through gaps in damaged endothelium. They get trapped in the subendothelial space. the area between the intima and media. Under normal circumstances, LDL would just pass through, but once trapped, something dangerous happens. Phase 2, oxidation-trapped LDL particles undergo oxidative modification. Free radicals attack the lipid components, creating oxidized LDL, OXLDL. OXLDL is toxic. It's recognized by your immune system as a danger signal, similar to how your body would recognize a bacterial invader. Phase 3, immune activation. Your endothelium starts expressing adhesion molecules, molecular Velcro that catches circulating monocytes, a type of white blood cell. These monocytes stick to the damaged area, squeeze through the endothelial layer, and enter the subendothelial space. Once there, they differentiate into macrophages, immune cells designed to engulf foreign material. Phase 4, foam cell formation. Macrophages start eating the OXLDL through specialized receptors called scavenger receptors. But here's the problem. These receptors don't have a feedback mechanism to stop uptake. The macrophages keep eating OXLDL until they're completely engorged, bloated with cholesterol. We call these lipid-stuffed macrophages foam cells because under a microscope they look foamy. Phase 5, chronic inflammation. Foam cells release inflammatory cytokines, TNFA, IL-1V, IL-6, that attract more immune cells. A vicious cycle develops. Inflammation attracts immune cells, which create more inflammation. Eventually, foam cells die and rupture, spilling their contents. Smooth muscle cells migrate from the media layer and start depositing extracellular matrix. Calcium precipitates out of solution and forms deposits. Over years, this evolves into mature atherosclerotic plaque, a complex structure containing lipid-rich necrotic core, dead foam cells and cholesterol, fibrous cap, smooth muscle cells and collagen, inflammatory cells, ongoing immune response, calcium deposits, hydroxyapatite crystals. This is atherosclerosis. But here's where it gets interesting. The remodeling paradox. In medical school, we're taught that atherosclerosis progressively narrows arteries until blood flow is choked off. The pipe gets smaller, symptoms develop, eventually you have a heart attack. But this model is wrong for most heart attacks. In the 1980s, a pathologist named Seymour Glagov made a remarkable discovery by studying hundreds of coronary arteries at Autopsy. He found that as plaque accumulates, the arterial wall doesn't just sit there passively, it actively remodels outward. The entire vessel expands to accommodate the growing plaque while preserving the internal diameter. Think of it like this. Imagine you're building a house and you need more storage space. Instead of making the rooms smaller, you expand the entire house outward. The living space stays the same size despite adding storage. That's what your arteries do. This is called positive remodeling, or the Glagov phenomenon. It means you can have massive plaque burden, 40%, 50%, even 70% of the vessel wall occupied by atherosclerotic disease, but the lumen, the opening where blood flows, remains wide open. Blood flows normally. Oxygen delivery is adequate. You have zero symptoms. This is why marathon runners drop dead mid-race. This is why the healthiest person in your gym suddenly collapses. This is why 50% of men have sudden death as their first cardiac symptom. Their arteries had been silently remodeling for decades, hiding massive plaque burden behind normal blood flow. The two types of plaque, stable versus vulnerable. Not all plaques are equally dangerous. Stable plaques, thick fibrous cap, protective covering, dense calcium deposits, small lipid core, low inflammatory activity, grow slowly over decades. These plaques can cause progressive stenosis, narrowing. Eventually, you might develop exertional angina, chest discomfort during exercise that resolves with rest. They're dangerous, but they give warning signs. Vulnerable plaques, the killers. Thin fibrous cap, 70% limits flow during exercise. Myocardium becomes ischemic, EKG changes appear, test is positive. But stress tests only detect flow-limiting stenoses, the stable plaques causing significant narrowing. They completely miss vulnerable plaques with thin caps, cause 20%. CAC score is the single best predictor of future cardiac events. Better than Framingham risk score, better than any biomarker panel, better than stress testing. It's a direct measurement of disease burden. But CAC has a critical limitation. It only visualizes calcified plaque. Remember the vulnerable plaques with thin fibrous caps and large lipid cores? They don't have significant calcium. CAC misses them entirely. CCTA, seeing the invisible. To visualize soft, vulnerable plaque, you need coronary CT angiography, CCTA. This is the gold standard for non-invasive coronary assessment. The procedure, IV contrast dye injection, high-resolution CT scanner, 256 plus slices, ECG gated acquisition, images timed to specific cardiac phases, advanced post-processing and 3D reconstruction. What CCTA reveals: calcified plaque, bright white, dense calcium; non-calcified plaque, darker, lipid-rich, vulnerable; mixed plaque, combination of calcified and non-calcified components; exact stenosis percentage, measured quantitatively; plaque morphology, thin cap, large necrotic core, positive remodeling. CCTA is the only non-invasive test that can identify the vulnerable plaques that cause sudden death. My personal screening protocol, based on 30-plus years of clinical cardiology and reviewing the evidence, here's my approach. For everyone age 40-plus, baseline CAC scan. If CAC on 0, repeat in 5 years. If CAC on 199, aggressive risk factor modification, repeat in 3.5 years. If CAC on 100, 3999, CCTA to assess plaque composition, very aggressive prevention. If CLOC FAR 400, CCTA plus cardiology consultation, consider invasive angiography. For high-risk individuals, strong family history, diabetes, chronic kidney disease, CCTA starting at age 40 or 10 years younger than age of earliest family event. Serial imaging every 3 to 5 years to track progression for symptomatic patients or athletes with concerning features. CCTA, regardless of age, any chest discomfort, unexplained dyspnea, syncope, or palpitations warrant imaging. I personally get CCTA every 3 years despite optimal lipids, LDL 65 mg DL on statin plus ezetimibe, and regular exercise. Why? Because I've seen too many low-risk patients with significant disease discovered only after sudden death or acute MI. I refuse to be one of them. Closing thoughts: that 42-year-old CrossFit coach I mentioned at the beginning, his death was preventable. A CCTA would have shown the vulnerable plaque in his LAD. We could have intensified lipid-lowering therapy, statin plus PCSK9 inhibitor to drive LDL below 50, started antiplatelet therapy, modified his training to avoid dangerous heart rate spikes, potentially performed elective PCI. If the lesion was severe enough, he'd still be alive. But nobody looked. He had normal blood work. He felt great. Everyone assumed he was healthy. We have the technology to see coronary disease decades before it kills. We can identify vulnerable plaques. We can quantify risk with precision. But we don't use these tools systematically because insurance companies resist covering screening in asymptomatic people. Many physicians still rely on outdated risk calculators. Patients don't know to ask for these tests. You don't have to accept this. Control your blood pressure. Every 10 mm elevation increases CAD risk 30%. Optimize your lipids. LDL, 70 mg DL, or even 50 if high risk. Manage blood sugar aggressively. Even prediabetes accelerates atherosclerosis. Exercise strategically. Zone 2. Plus, HIIT builds collaterals and improves endothelial function. Get proper imaging. CAC and CCTA reveal what blood work can never show. Don't guess about your coronary health. No, the Widowmaker doesn't care about your gym routine or your clean diet. It cares about the biology happening inside your arterial walls right now. Find the fire before your house burns down. This is Dr. Eric Topol. Your heart's fate isn't predetermined, but ignorance is deadly.